Okay. So maybe the question is, why is a prolonged administration? And the second question is the severity of the patient, of the severity that we expect when we have to take in charge the patient. If I have a patient and he arrived in the ICU, and it's a post-operative patient, and he has norepinephrine on peripheral catheter, and it is obvious that it's just for 1-2 hours, but everything is okay. The lactate is okay, and the patient is stable. Okay. But if the patient is not stable, and I saw that the lactate instead of decreasing is increasing, so the story is not the same. So the same study, because it's the only study who randomize the two strategy. And what is interesting in this study, it's a prolonged administration because they look at during many, many days. So it's a real life if we want to start only with a peripheral catheter. And the severity of the patient is it's a severe patient with a high mortality. Most of the patients are ventilated. So it's true ICU patient. And what you can say is that you have more complication with a peripheral catheter. I am okay that complication could be the fact that it's difficult to find a peripheral access, but it's what we can see in ICU. And so sometimes it's difficult to find. And you can see also that there is catheter infection, and there is also thrombotic complication. So another point is that it's the famous Clover studies. And there is many patients who receive norepinephrine only on peripheral access. I just want to point out something, is that when you look at the complication with the peripheral access, it was very low number of extravasation. So a very good result. If you look at the complication of the central venous catheter, it's not a lot. And I was surprised by this. I thought that they will have more complication. And no, except the fact that there is arrhythmia. And we know that arrhythmia, it's most of the time when you insert the leader or when the catheter is not on the right place. Okay? But if I look at the infections complication or even pneumothorax, there is a very low complication. So I know we need training, we need expertise. Okay. But, you know, maybe it's the same with the peripheral catheter. I like this study because it's the real life. And and it's very well done. It's not a randomized study, but it's a prospective study. So they try to apply a very nice protocol. When they use norepinephrine or vasopressor with a peripheral access. And you can see initially, so they are very cautious. They take 2 access and they look at the localization of the venous access, and they use echography, and they assess the peripheral access every 2 hours. I like this. Because, you know, I have so many nurses in my ICU that it's easy to say, okay, look every 2 hours. And just to be provocative. And also, they have a maximum dose of norepinephrine. And also, they ask to the patient if there is pain or discomfort. And after, they feel confident with the protocol, so they try to increase the number of patients who can be included in the protocol. But you can see that there is the supervisor nurses who try to assess if the protocol was well respected. And at the end, also, they add another cautious measure is they, every 2 hours, they make an aspiration to be sure that the position of the catheter was right in the venous. So, really a very strict protocol. And what they observe that you can see that despite the fact that it was very strict, they had infusion of it was extravasation events, it's 5.5%. So it's not nothing. They specify that each extravascular events was not deleterious at the end. And also, half of the patient need a central venous catheter. Okay. So I just want to highlight the fact that it's very important, if we start with this strategy, to have a clear protocol and to be cautious about this. And you can see that most of the patients had the infusion dose of norepinephrine was lower than 24 hours. In mean, it was 4 hours. And when you increase the duration of norepinephrine infusion, you have more extravasation. So we have really to be cautious with this strategy. So just to, when in my unit we take trauma patient, and most of the trauma patient in France, they receive norepinephrine in a peripheral catheter. And so when the patient arrived at the emergency room, we look at the stability of the patient. If the patient is stable, we leave the venous catheter, and we pursue the catecholamine administration on the venous catheter. If the patient is unstable, we insert femoral catheter, and arterial and venous. It takes 20 minutes. And after, we remove this catheter 24 hours after, when the patient is in the ICU, and if he's stable. So to conclude, I think it's very important to give vasopressor without delay, so a peripheral catheter could be useful to do this. And I think that if the patient is, it's obvious that the severity of the patient is high, and if it's obvious that you have to keep norepinephrine, I think that a central catheter must be considered. And if you start with a peripheral line, it's important to have a clear protocol. Thank you.
Thank you very much. Are there some questions in the room? Because we have two very different points of views. I have a first question for you, Professor Duranteau. What would be your cutoff for prolonged infusion?
I don't know exactly, but it's for me it's 6 hours.
Okay.
Just to give a number.
And I have another question for both. Oh, sorry, we have a question in the room, please.
What about the dose? Is there any dose that we shouldn't use a peripheral catheter?
I can try. I think, unfortunately, there's no good answer to that, right? I'm curious to hear what you have to say as well. One of the things that makes me nervous, we dose our norepinephrine, for instance, the way that it was done in the last study that you mentioned, mics per minute. I understand that many units will dose it as mics per kilo per minute. I think we need to be really careful. Although that second one makes a lot more sense to me physiologically, it doesn't matter for externalization, at least intellectually doesn't matter to me, right? A bigger person doesn't care if they have, what they really care is the dose that's going in. So I think we need to be careful about what dosing we're talking about. Our protocols, which we adopted where I am currently from, protocols that existed in some of these trial sites. One institution I work at has a max of 10 mics per minute peripherally, one has 20 mics per minute of norepinephrine as their dose. I think it's fairly arbitrary, and following other groups who have done it. But to my knowledge, there's not great data on it.
Yes, I agree with you. And I say 6 hours, it's because 6 hours is the time to see if the patient is recovering or if the patient is worsening. So for me, it's when, for example, I have a post-operative patient, the 6 hours, it's give me the idea that the patient will recover or the patient is on a bad shape. So I shift at this time.
Can I just add one more thing? I'm so sorry. One more thing I just wanted to add. I feel like this happens a lot to us for hypertonic saline as well, where we do that peripherally. Sorry, is this not? I'm sorry.
This one.
It has to be red.
This, sorry, now you're stuck with my voice. Okay. One of the things I would think about, I think about this with hypertonic saline as well, because we have a protocol up to a certain dose. Often our patients have more than one IV. That's how much can go through a given IV, right? It's not about the amount peripherally. And I think certainly the way our protocols are written, our nursing staff sometimes misinterprets that. That says if you are giving it peripherally, it can only be up to 20 mics per minute, right? But what that really is talking about is the extravasation at a given site. And so we will sometimes say to them, we'll just add it at the other IV. Sorry.
Yeah, so good afternoon, Philippe Bauer from Mayo Clinic. I have a comment and I have a question for you. First comment, I mean, in our policy is 48 hours because, it depends on the patient. I'm not talking about trauma. If you take a MICU, for example, most of the patients that we have are off norepinephrine within 18 hours, 24 hours. You take the septic shock from urosepsis, for example, they have a better outcome for the same given of norepinephrine. So you need to tailor to your patient. And of course, if you have a 22 gauge, you're not going to put any norepinephrine because you're going to extravasate. So you need to adjust to the situation. Same for a central line. We have a lot of transplant people who have had renal access difficulty on the past. Sometimes you cannot put a line. You have to ask IR to do that. So you have to start your norepinephrine because we believe in the one bundle. My question for you, for the two of you, is what about adding a second agent such as vasopressin? What's your policy or practice?
So at the institutions at which I work, it is not part of our policy to allow for that. When I have talked to other people who have similar policies, the explanation, which I'm not sure I think makes an enormous amount of sense, but the explanation is the absence of an antidote. Realistically, if you look at the frequency with which we use the antidotes for the other vasopressors due to extravasation, I think it's very low. So I'm not entirely sure that that's a reasonable reason to exclude it. At the same time, I think as institutions, at least that I've seen, have transitioned to allow this because of that. They start with not allowing vasopressin peripherally.
So if I think about vasopressin, right now, maybe it will change, but right now is the second vasopressor that we will use. We can discuss about this. But if I think vasopressin in septic shock, for example, it's because my patient is worsening, and with norepinephrine, I'm not able to control enough. So for me, it's time, if I have not, to have a CV, central venous catheter. And vasopressin, we know nothing about the potential complication with the peripheral line. So I will be very cautious about this. And for me, it's not logical to stay with a peripheral catheter if I have norepinephrine and vasopressin. And if I want to start directly vasopressin, I will start on a central venous catheter.
Are those the questions? I have a last one, maybe. I have heard your point of view about central venous catheter, but what about arterial catheter in these patients receiving vasopressor?
Okay, I should admit bias. I am very much a zealot for what I'm about to say, so I'm not going to say that it's the most balanced view. I personally am not in favor of them. I should say I work in a medical ICU population, so obviously I take care of people who come to me without catheters usually, and so the decision is for me and whether or not we should place one. I'm unconvinced that there is any evidence that suggests that they improve patient outcomes. So I use them very rarely.
So, no. And when I use a vasopressor, just trying to stay logical, because I think you need vasopressor, and so most of the time we use the arterial catheter. For example, if it's in ICU, it's clear. In the operating room, if we have to deal with a high-risk surgical patient, we start with an arterial line.
Thank you very much to both of you. I think we will finish this debate now, because otherwise we won't find the consensus before the end of the night. Thank you very much.
Thank you.